Rheumatologist and Research Lead for University Hospital of Leicester in the United Kingdom. This is a rheumatology case series for Farz Academy. We're going to go through some questions for spondyloarthropathy, and hopefully at the end of these questions you'll be able to have some basic idea about spondyloarthropathy and its management, and you'll be aware of some of the common topics coming in MRCP Part 2 questions. Right, so just to give you an overview of spondyloarthropathy, this terminology is used for inflammatory spinal conditions involving mainly the axial skeleton. Conditions can involve the peripheral joints as well as extra-articular manifestations. Mainly include seronegative spondyloarthropathy, ankylosing spondylitis, psoriatic spondyloarthropathy, as well as reactive arthritis. In coming slides, we will discuss some questions regarding the diagnosis, management, as well as test results for these conditions, and hopefully at the end of the presentation you will have a basic idea of this and the favorite topics for MRCP question writers. Right guys, so the first question is regarding a 30-year-old lady with a diagnosis of ankylosing spondylitis, presents with headaches. She has painful left eye and she also reports blurred vision. On examination, the eye is red, photophobic, pupils are small, and the reflexes are sluggish. Although the visual fields are normal, she still reports blurred vision. Recent full blood count, UNEs, creatinine, liver function tests are all normal. So the question is, which one of the following is the most likely diagnosis? Number A, scleritis, B, corneal melt, C, blepharitis, D, uveitis, E, conjunctivitis. So you have most likely guessed it right. Answer is D, which is uveitis. Uveitis is an association with ankylosing spondylitis, and patients are at risk of developing it. It's more of a HLA-B27 disease spectrum where eyes are involved as well. Blepharitis is more of an eyelid inflammation, and conjunctivitis symptoms are usually mild and more common with the rheumatoid arthritis type of a scenario. Corneal melt again is perforating corneal ulcerations and end-stage keratitis, mainly with rheumatoid arthritis, especially untreated or resistant disease. Patients with corneal melts will have typical findings of opacities and ulcerations. Scleritis presents as a blue discoloration. It could well be redness of the sclera with associated pain and tenderness. Usually does not cause photophobia, and the reflexes are usually normal. Right, so the second question is regarding a 32-year-old man with a 7-month history of pain and stiffness of his lower back. He was referred to the clinic for review. Pain was worse, particularly in the mornings after rest, and improved after a warm shower. He worked as a laborer at a construction site and often lifted heavy objects at work. More recently, he has noticed some pain in his right buttock, which often kept him awake at night. In addition to the back pain, he also complained of increased lethargy, tiredness that had been more prominent during the previous 2 months. He denied any weight loss or anorexia. He had no past medical history of note apart from 10 months previously. He had an episode of heel pain that resolved after an injection from his general practitioner. Blood results showed normal hemoglobin, leukocyte count, as well as platelets. Renal functions and electrolytes were normal as well. CRP was marginally raised at 22. So when he gone to see the general practitioner, the following appearance was seen on a plain X-ray of his lumbar spine. So there is a X-ray for you guys to have a look at. Question is, which one of the following features in his history should prompt further investigations of his back pain? A. Nature of his pain and past medical history. B. The findings on his lumbar spine X-ray. C. History of possible trauma. D. His age. E. Elevated serum CRP results. So what you need to realize in this question is that the X-ray lumbar spine is not usually diagnostic for any significant conditions written in here, and if they are pointing towards ankylosing spondylitis as a diagnosis based on X-ray, they usually give you a sacroiliac joint X-ray rather than a lumbar X-ray, so you just need to keep that in your mind. So the answer here is A. Nature of his pain and past medical history. Obviously, he is describing inflammatory back pain, worse with rest, especially in the mornings, better with activity. Right-sided back pain could point to right-sided back pain and buttock pain could point towards sacroiliitis. And the story about heel pain is plantar fasciitis, which is not uncommon with inflammatory spondyloarthropathies, because what you have to remember is that it's enthesitis inflammation as a pathology. The patient is quite young, and that's the group where patients commonly present. More common in males. X-ray of the lumbar spine is unremarkable, and as I previously mentioned, that they usually will show you sclerosed SI joint rather than a lumbar X-ray. If a history of trauma, then it would have been more acute pain and with some radiculopathy if disc prolapse is a possibility. CRP results are high, marginally raised, not uncommon in spondyloarthropathy. If it would have been significantly high, you would have thought about possible discitis, infective discitis, or a TB maybe. So most likely answer here is that further investigations are needed, especially in view of this inflammatory sounding back pain. You need to realize that inflammatory back pain means worse with rest, better with activity. In ankylosing spondylitis, common questions which point towards it is buttock pain, and waking up early in the mornings is also an inflammatory symptom. Right, so the question 3 is regarding a 24-year-old Caucasian athlete presents to outpatient department complaining of a 3-month-long history of aches and pains. He used to be a very active runner, but since a hip injury about 8 months ago, he has been forced to give up competitive running. 3 years ago, he was seen in the emergency department with a painful red eye, for which he was treated with eye drops. There's no history of skin rashes or mucosal ulcerations. His father suffered from severe gout and his mother had rheumatoid arthritis. On examination, the right first metatarsophalangeal joint was swollen and tense, tender, but all the other joints were unremarkable. Rotation of the lumbar spine was restricted. The question is, which one of the following tests would be most useful in confirming the diagnosis? A. HLA-B5 antigen typing. B. Serial serum uric acid levels. C. Rheumatoid factor. D. HLA-B27 antigen typing. E. Examination of the joint fluid for crystals. Now you do need to read the questions really carefully and look for negative possibilities as well. For example, there's no skin rash or mucosal ulceration, so you need to think about that. Young man, again, with the age you can rule a few things out as well. So just read the question very carefully before answering. Right, so the answer is D, which is HLA-B27 antigen typing. History of joint pains with back pain and restricted range of movement in a very young athlete of in his 20s is pointing towards a possible ankylosing spondylitis. He also had a history of red eye, which again points towards uveitis. With no ulceration, so you don't think about 𝑨𝒃𝒐𝒖𝒕 and HLA-B1 is not indicated in this scenario. Reactive arthritis again could be a possibility. The radiographic changes in ankylosing spondylitis is usually sacroiliitis initially, which could be seen in reactive arthritis as well. HLA-B27 is positive in 90% of the patients with ankylosing spondylitis and 75% with reactive arthritis. 8% of the normal Caucasian population can have HLA-B27 positivity as well. So you need to make sure when you are reading the question that you look at the negatives as well, so you can rule some of those options out easily. Right, so question 4. A 39-year-old lady with a 2-day history of painful and swollen right knee is referred to outpatient clinic by her general practitioner for further management. She denies any history of trauma, does not have any previous history of joint problems. Over the last 5 days, she has noticed redness and soreness in her both eyes. She does not smoke and drinks about 8 units of alcohol weekly. On examination, she has fever with a temperature of 101.3, eyes are red, and she has brown macular rash on the sole of her feet. Her right knee is hot, swollen, and tender to palpate. No other joint appears to be affected. Hemoglobin, white cell count, platelets are normal. ESR is raised at 72. Renal functions and electrolytes are normal. There's no growth on her blood culture. Urine analysis showed no blood glucose or protein, and X-ray of the knee showed soft tissue swelling around the left knee, otherwise was normal. So the question is, which one of these is the most likely diagnosis? A. Viral arthritis. B. Gout. C. Rheumatoid arthritis. D. Gonococcal arthritis. E. Reactive arthritis. Right, so answer is E. Reactive arthritis. Clinically, a classical reactive arthritis is a triad of urethritis, conjunctivitis, and arthritis. Usually affects the larger joints, weight-bearing ones, especially knees and ankles, can involve hips as well. Not the full triad is always present in a patient. It can be triggered by a dysenteric infection and even viral infections as well. STDs can cause arthritis as well. The characteristic rash is keratoderma blennorrhagica, and I would probably recommend to you guys to go on Google and have a look at a few of the pictures of that, because sometimes examiners can just give you a picture of a rash, and it's a classical rash and diagnostic scenario sometimes. It's mainly on the palms and soles of hands and feet. Non-steroidals can help. Treating the infection usually sort things out. If this question would have had an option of aspiration and sending it for cultures, that would probably be the most appropriate answer, because although the presentation was quite classical, you still need to rule out a septic arthritis. Any monoarthritis, inflammatory sounding monoarthritis with patient having fever, you need to rule out infectious pathology, and aspiration and sending it for cultures would have been the most appropriate way forward. That would have helped in ruling out any crystal arthropathy as well. Right, so question 5, a 30-year-old Caucasian lady presents to the outpatient department complaining of a 3-month history of lower back pain, which is worse first thing in the morning. Intermittent pain and swelling of her left ankle, although she had an injury to this while working in a dairy firm about a year ago. 3 weeks ago, she was seen in emergency department with painful red eye, for which she was treated with eye drops. She denied any skin rashes or mucosal ulceration, so again, negatives, very important. On further inquiry, she does have a history of chlamydia, which is STD, 5 months ago. On examination, her left ankle was swollen at the site of Achilles tendon insertion, but all the other joints were unremarkable. Flexion of the lumbar spine was reduced. Which one of the following is most plausible diagnosis? So you have to realize, if they say the swelling was at the insertion of the tendon, that's enthesitis, and you do have to think about ankylosing spondylitis or psoriatic type of picture. So A, rheumatoid arthritis, B, Behçet's, C, gout, D, ankylosing spondylitis, E, polymyalgia rheumatica. So again, you need to have a look at the age of the patient as well as negatives. So if you carefully read this question, you will be able to rule quite a few of these options out very quickly. Right, so the answer is D, ankylosing spondylitis. The story is very suggestive of that. It's when I previously mentioned about spondyloarthropathy being an umbrella term, so it does include reactive arthritis, ankylosing spondylitis, seronegative spondyloarthropathy, which could be related to IBD, so often called enteropathic spondyloarthropathy, and as well as psoriatic spondyloarthropathy. A subgroup of juvenile idiopathic arthritis can involve the spine as well. HLA-B27, as previously mentioned, is present in 90% of the patients with ankylosing spondylitis and 75% with reactive arthritis, as well as 8% of the normal population. Young female of 30, very unlikely to have gout, so that was a straightforward option to rule out. Also, there were no mucosal ulceration, so you can take Behçet's out as well. Ankylosing spondylitis could be very debilitating, and it should be considered as a diagnosis with any patient presenting with inflammatory sounding back pain. Management has come a long way, and now we have biologics as well, especially anti-TNFs, but on top of that IL inhibition like secukinumab and 𝑨𝒃𝒐𝒖𝒕. These are newer biologics. More recently, 𝑨𝒃𝒐𝒖𝒕, which is a JAK inhibitor, has been licensed for this condition. I will strongly recommend that you guys read ankylosing spondylitis guidelines and see what treatments are NICE approved and go through the mechanism of action of those treatments. Still, non-steroidal is the first line, and physiotherapy is very important as well. We do calculate disease activity through BASIDI and BASFI scores, so it might be worth just quickly looking into that as well. Unlikely that at the MRCP Part 2 level you will get a lot of questions about disease activities, but if you know the guidelines and what score cutoffs are, that would be helpful if one of the enthusiastic question writers are putting that in as well. Right, sixth and the final question is regarding a 32-year-old lady, 2-month history of painful and swollen left hand, index and middle finger, distal interphalangeal joints. So you need to make sure to remember the type of joint involved. She reports a few episodes when one of the fingers in her right hand swelled up as well. However, this has subsided completely after a week. She drinks 6 units of alcohol every week and has just returned from a holiday trip from abroad. She has no significant past medical history except her sister has psoriasis. On examination, there are swollen and tender DIP joints in the left index and middle finger. Investigations show normal hemoglobin, leukocyte count, neutrophils, but her ESR is raised at 43. So the renal functions and electrolytes are all normal. Rheumatoid factor is negative. Which one of the following is the most anticipated diagnosis? A. Reactive arthritis. B. Gout. C. Palindromic rheumatism. D. Rheumatoid arthritis. E. Psoriatic arthritis. Right, so the answer is E. Psoriatic arthritis. Apologies for the very busy slide. This patient has typical distal interphalangeal joint involvement with a strong family history of psoriasis in first degree relative, her sister. Psoriatic arthritis can present in 5 clinical phenotypes. First one is like exactly rheumatoid arthritis with symmetrical joint involvement. In this patient, it was asymmetrical. So second type is where you get distal interphalangeal joint involvement with nail pitting as well as onycholysis, where the nail comes off from the nail bed. Oligoarticular involvement with larger joints is the third type. You can have spinal involvement as well, which is axial pattern. And the final one is what we call arthritis mutilans, which is 5% of the total population with psoriatic arthritis. It's very destructive, and telescoping of the digits happen in this scenario. There's no clear history of infection in this history, so reactive arthritis is unlikely. Rheumatoid arthritis is usually symmetrical. Right, so the gout is unlikely in this scenario because they haven't given any risk factors for that. For example, age, history of cardiac failure, or diuretic use, as well as high alcohol intake. Palindromic rheumatism presents in a different pattern with migrating joint involvement, and you will usually have a period of normal joints with no synovitis. Right, so hopefully you have some understanding of spondyloarthropathy. What you need to realize is this is an umbrella term, and you know the subtypes now. HLA-B27 is important, and in this type of syndrome, eye involvement, especially uveitis, is not uncommon. So any patient in a question with eye involvement and back pain, you need to think about this condition. On top of that, inflammatory bowel disease can cause spondyloarthropathy as well. So look at the history from that scenario, as well as history of psoriasis is very important. Management, as I mentioned, we do Best-Dice scores as well as BESIFIs. So if the score is more than 4.2 and the patient hasn't responded to non-steroidal, then biologics is indicated. Anti-TNFs is the licensed biologic. On top of that, now we have IL inhibition as well, like I mentioned, secukinumab as well as ixekizumab, and more recently JAK inhibitor upadacitinib has been licensed as well. So I will strongly recommend you guys read about the NICE guidelines, and that will give a clear idea, because there could well be a few questions regarding up-to-date NICE guidelines. Many thanks for listening to this, and if you have any questions, I'll be happy to answer through the Farz Academy.